All right, thank you very much, Dr. Hamlin. It's really an honor and privilege to be invited to speak here today about improved understanding of disease biology and changing therapeutic paradigms in mantle cell lymphoma. These are my disclosures. So for today's talk, I'm going to focus first on the pathobiology of mantle cell lymphoma and some of the new insights into the disease biology, as well as novel mechanism-based therapies that have been developed based on an understanding of the disease biology, and some new approaches to the treatment paradigms, both for frontline mantle cell lymphoma as well as relapsed refractory mantle cell lymphoma. So mantle cell lymphoma is an uncommon subtype of B-cell non-Hodgkin lymphoma, representing approximately 6% of NHLs. It's a disease of the older individual with a median age of presentation of 68 years. Men are affected more than women, and generally speaking, patients present with advanced stage disease. Common sites of extranodal involvement are the bone marrow and GI tract, as shown in this picture here, with a presentation of lymphomatous polyposis, where you can see the nodular involvement with mantle cell lymphoma in the colon. Mantle cell lymphoma is typically aggressive, although as we'll discuss, the disease biology is heterogeneous, and this is thought to be an incurable entity characterized by initial disease remission after therapy, but subsequent relapses and shorter and shorter intervals of remission over the course of disease. The genetic hallmark of mantle cell lymphoma is the translocation between the chromosomes 11 and 14, which juxtaposes the CCND1 oncogene with the immunoglobulin heavy chain complex. And this drives the overexpression of cyclin D1, which is thought to be the initiating oncogenic event in mantle cell lymphoma. Cyclin D1 is an important regulator of the cell cycle. It complexes with the cyclin-dependent kinases 4 and 6 and leads to the activation of E2F, transcription factor, which drives the progression of the cell cycle through G1 toward the S phase. In addition to cell cycle regulation, cyclin D1 is an important protein mediating epigenetic modulation within the cell, transcriptional regulation, and chromosomal instability. However, the cyclin D1 overexpression alone is insufficient for the development of mantle cell lymphoma. And as such, we're interested in understanding other genomic alterations and pathogenic mechanisms in this disease. On the left, you can see a tile plot of the initial whole exome sequencing that describes the genomic landscape in mantle cell lymphoma. In this study, 29 cases of patients were sequenced, and we can see that the most commonly recurrent mutations in mantle cell lymphoma involve DNA repair pathways, such as the ATM gene, CCND1, and P53 alterations. Under the mentorship of Dr. Zelenitz, we have looked here at Sloan Kettering at 55 cases of newly diagnosed mantle cell lymphoma, and using a targeted sequencing platform characterized the genomic alterations in this disease, and have recapitulated some of the original work, finding that, you can see here, ATM and P53 mutations are very common. In addition, this work has shown that genes that are epigenetic modifiers, such as WHSC1 and MLL2, are also important in the pathogenesis of mantle cell lymphoma. We are particularly interested in trying to correlate these genomic alterations with outcome. And what we found in our work was that the presence of P53 genetic alteration is associated with inferior overall survival, as shown in this survival plot here. And this has also been shown in other series as well. The proliferation signature is also an important predictor of outcome in mantle cell lymphoma. This work, which was published in 2003, characterized 20 genes that are associated with cellular proliferation and found that high expression levels of these genes were associated with inferior overall survival, as is shown here. Gene expression profiling is not easy to do in common clinical practice, and it has been useful to know that the MIB1 or Ki67 immunohistochemical marker is a good surrogate for the gene expression profiling estimates of proliferation signature in mantle cell lymphoma. And report of Ki67 level is really a standard part of pathologic workup for mantle cell lymphoma and helps us to risk stratify patients. The Ki67 has also been incorporated into a clinical prognostic tool called the Mantle Cell Lymphoma International Prognostic Index, or MIPI. And here we can see that incorporation of Ki67 to other clinical factors, such as age, performance status, LDH, and white blood cell count, do risk stratify patients in mantle cell lymphoma, defining low, intermediate, and high-risk disease groups with markedly different survival outcomes. Recent work involving molecular profiling of mantle cell lymphoma has defined the biologic characteristics of indolent mantle cell lymphoma. Although I've had a limited time as a practicing attending the past 2 years, we do see patients who present to us with indolent mantle cell lymphoma, and these patients are characterized by leukemic phase disease, splenomegaly, and absence of lymphadenopathy. They oftentimes present asymptomatic, and interestingly, this work has sought to characterize the biology of these patients. So here we can see that the naive B cell that harbors the 1418 translocation will localize into the mantle zone of a lymphoid follicle. And then there are different pathways of progression. In indolent mantle cell lymphoma, this will progress through the germinal center, resulting in somatic hypermutation of the IgHV, and will lack expression of SOX11. These are pathologic characteristics that lead to indolent disease biology and genetically stable mantle cell lymphoma, oftentimes with a low proliferative index. This is in contrast to classic mantle cell lymphoma, where typically patients will have an unmutated IgHV, they will express SOX11, and are oftentimes genomically unstable with elevated proliferation indices. So based on the work that I just described, I think it's clear that mantle cell lymphoma is not one disease and that it is biologically heterogeneous. And we can define the low-risk subgroups like I just described to you with a low proliferative rate and SOX11 negativity, stable karyotypes, and IgHV hypermutation. As well as high-risk patients who present with morphologic features of blastic, blastoid, or pleomorphic, and in contrast will have high proliferative rates and genomic instability and oftentimes harbor p53 alterations. But interestingly, the majority of mantle cell lymphoma patients actually fit somewhere in the middle, and over time, mantle cell lymphoma can evolve across this paradigm. So, understanding the various aberrant cellular pathways in mantle cell lymphoma has really led to the development of many exciting mechanism-based treatments in this disease. This figure depicts the various cellular pathways which have been targeted by mechanism-based therapies. In mantle cell lymphoma, there's constitutive activation of the B cell receptor pathway, and there are many convergent downstream signaling pathways that eventually lead to increased cellular proliferation and survival. In mantle cell lymphoma, ibrutinib, the Bruton tyrosine kinase inhibitor, shown here, has been found to be an effective therapeutic modality. In addition, targeting the PI3 kinase, AKT, and mTOR pathway are successful therapeutic strategies. Lenalidomide is an immune modulatory agent that binds to the cereblon protein. Bortezomib and carfilzomib are proteasome inhibitors. We'll talk a little bit more about venetoclax, which Dr. Gerasitano mentioned earlier, as a BCL2 inhibitor that has efficacy in this disease. In addition, the drugs that target the cyclin-dependent kinases 4 and 6 are active, as well as HDAC inhibitors. I'm just going to highlight a few of these biologically targeted therapies in the next few slides. One is ibrutinib, which has recently been FDA approved for the treatment of relapsed refractory mantle cell lymphoma, and as I previously mentioned, inhibits BTK and decreases NF-kappa B activation and cellular proliferation. This drug was shown to have a relatively high overall response rate in the relapsed refractory mantle cell population, with an overall response rate of 68%. However, only a small proportion, or relatively small proportion of patients achieved a complete response, 21%. And unfortunately, the median duration of response is less than 2 years, and the progression-free survival over just a year, 14 months. Lenalidomide is another exciting agent in the relapsed refractory mantle cell lymphoma, which has been FDA approved. It has a wide variety of different anti-tumor effects and modulates the immune system to increase Th1 cytokines such as IL-2 and interferon gamma, leading to the increased activity of cytotoxic T cells and increased activity of NK cells. It also seems to inhibit angiogenesis and downregulates the activity of cyclin D1 in mantle cell lymphoma. As a single agent in the relapsed refractory setting, it was associated with relatively modest overall response rate of 28%, with marginal complete response rate of around 8% and short duration of benefit. Venetoclax has been recently FDA approved for the treatment of CLL, however, is not approved for the treatment of mantle cell lymphoma. However, as John Gerasitano, my colleague, earlier presented, venetoclax has shown exciting activity in the phase 1 trial for mantle cell lymphoma. Venetoclax is a BCL2 inhibitor and is a BH3 mimetic protein, which leads to the initiation of programmed cell death, as is shown here in these pictures here. In the phase 1 study with a relatively few patients, 28, we saw impressive overall response rates of 75%, and again, a lower proportion of patients achieving a complete response, 6 out of 28. However, among these patients who achieved a complete response, durable remissions were noted, and this is from last year's ASH presentation. We see that among the patients who achieved a CR, durable remissions were seen out to as far as 24 months. So when we look at the various biologically targeted agents in relapsed refractory mantle cell lymphoma here, the first three, bortezomib, lenalidomide, and ibrutinib, all being FDA approved for the treatment, and then others, PI3 kinase inhibitor, idelalisib, mTOR inhibitor, temsirolimus, CDK4/6 inhibitor, BCL2 inhibitor, and HDAC inhibitor. I think what's really striking in this image is really the lack of the color red, which correlates with few complete responses, relatively speaking, and although in some cases overall response rates approaching or exceeding 70%, most of these responses are partial remissions, and many of these responses are not durable. So there's an interest in trying to improve the complete response rate and enhance the efficacy of these biologically targeted agents for the treatment of relapsed refractory mantle cell. And one approach is to try to combine different biologically targeted agents that may synergize and work on parallel pathways. So my colleague, Dr. Connie Bott-Levy, is leading this phase 1 study of buparlisib, a pan-PI3 kinase inhibitor, and ibrutinib for the treatment of relapsed refractory mantle cell, follicular, and diffuse large B-cell lymphoma. In this trial, the biologic rationale is really that dual targeting of PI3 kinase and BTK will lead to synergy and improvements in efficacy and durable remissions. And thus far, there has been exciting activity in the initial patients who have been enrolled in her phase 1 study. So we'll look forward to those results in the future. For standard frontline therapy in mantle cell lymphoma, interestingly, this does not include biologically targeted agents. Historically, for the treatment of newly diagnosed mantle cell lymphoma in patients who need to initiate therapy, we have used cytotoxic chemotherapies. So for patients who are younger or transplant eligible, they usually will undergo an intensive induction strategy that includes cytarabine. And this is oftentimes followed by high-dose therapy and autologous stem cell transplant. For the transplant-ineligible patient or older individual, the standard induction regimens that are commonly used are R-CHOP therapy followed by R maintenance or bendamustine in combination with rituximab. We believe that adding some of the biologically targeted agents that I previously described to frontline treatment paradigms may improve outcomes. And this is the basis for our current phase 2 study, where we are combining lenalidomide with a standard chemotherapy platform of R-CHOP and high-dose cytarabine, and are eliminating the high-dose therapy and autologous stem cell transplant component in favor of a maintenance strategy of 6 months of rituximab and lenalidomide. Dr. Paul Hamlin has led our effort in a randomized phase 3 study called the SHINE study in elderly mantle cell lymphoma, combining ibrutinib with a bendamustine and rituximab-based platform, followed by maintenance phase. And we eagerly await the results of this study, which potentially could be practice-changing for many mantle cell lymphoma patients. And I think exciting future directions for the frontline treatment of mantle cell lymphoma include a study that we hope to open in the future here, looking at the BR platform in combination with ibrutinib and the BCL2 inhibitor venetoclax. And then there are some intriguing trials looking at chemo-free therapies, such as the R-squared therapy that was published by Ajia Rawana in the New England Journal, as well as the so-called OASIS study, which will combine obinutuzumab, venetoclax, and ibrutinib in what will likely be a highly effective chemotherapy-free platform. So how do we bring together some of the information I was talking before about the disease biology and risk stratification into guiding our treatment selection for patients? One area is in the area of indolent mantle cell lymphoma, which represents a subset of patients, but nevertheless, these patients are candidates for potential initial expectant monitoring or initial observation. And we looked at this here at our group of patients, a retrospective cohort of patients at MSK, about 400 patients, and we looked at the outcomes for patients who were initially expectantly monitored as documented in their physician note because of a variety of different reasons, but largely speaking, they shared some clinical features, such as being asymptomatic at presentation. They didn't meet traditional Guelph criteria, which are indicators for initiation of therapy in indolent lymphoma. They oftentimes had leukemic phase disease and absence of lymphadenopathy or potentially isolated GI tract involvement. And what we see is really that there does not seem to be any decrement in overall survival with an initial expectant monitoring approach. The patients in the black curve who were expectantly monitored actually had a significantly improved overall survival. However, that likely reflects the more favorable disease biology. And interestingly, the median overall survival for these patients who are initially expectantly monitored is around 10 to 11 years. Other ways that we can incorporate disease biology into selection of therapy is by identification of biomarkers for sensitivity and resistance to biologically targeted agents. There's been increasing work to try to define mechanisms of resistance to the BTK inhibitor ibrutinib, such as mutations at the binding site or constitutive activation of downstream PLC gamma. In addition, there's preclinical work that's describing differences in mantle cell lymphomas that have activation of the alternative NF-kappa B pathway as a result of mutations in TRAF2, BERK3, or NIC, which renders them less sensitive to ibrutinib therapy, which targets the traditional or classical NF-kappa B pathway. In addition, we are interested in trying to use minimal residual disease as a biomarker of response in mantle cell lymphoma. The Europeans, both the Nordic MCL group as well as the EU MCL group, have found that using PCR-based techniques, that MRD is a powerful prognostic predictor in mantle cell lymphoma. Both prior to transplant as well as post-transplant, we can see splaying of these curves for patients who are MRD positive. They have negative, more inferior outcomes as compared to those who are MRD negative. And so one can imagine, similar to the PET-adapted strategies that Dr. Moskowitz discussed for Hodgkin lymphoma, that in the future MRD could potentially be a biomarker that will allow us to see patients after initial treatment. If they're MRD positive, perhaps their therapy would be further escalated. However, in patients who achieve MRD negativity, perhaps no further treatment would be indicated for patients who achieve a deeper response. So in conclusion, I believe that the improved biologic understanding of mantle cell lymphoma has refined our ability to risk stratify these patients, and insights into the abnormal cellular pathways in mantle cell lymphoma has led to the development of many exciting biologically targeted therapies. And in the future, we hope to incorporate these treatments into frontline paradigms and look at exciting synergistic combinations in the relapse refractory setting, and also utilize baseline risk stratification tools and biomarkers of response to tailor therapy in mantle cell lymphoma. I would like to thank all of my colleagues in the lymphoma service, and I'd like to really take this opportunity to thank Dr. Moskowitz and Dr. Zelenitz, who really have been truly incredible mentors, inspiring examples of amazing clinicians and researchers who have changed the field in lymphoma, and I really find it such an honor and privilege to be able to have learned from them these past years, and truly lucky to be able to honor them at this symposium and this evening. And I'd also like to thank the patients and families who participate in our trials here. Thanks.